Hi class. In this lecture, I will review the general principles of pharmacology. This lecture provides a basis for how drugs act on the body and what the body does in response, which could be actions such as exertion of a therapeutic action, or it could even be how the body's physiologic processes act to rid the body of the drug. Understanding these basic concepts makes it easier for you to grasp the pharmacology principles of each drug that we will present throughout this semester. So all lessons start with vocabulary. Please know these terms. You can find the definitions in the assigned chapter readings. And these are the lesson objectives for this particular lecture. All right, so let's get started. So I like pictures. I think it makes concepts easier to understand, especially new concepts or ideas. So I will use this diagram several times throughout this lecture to walk you through some of the basics of pharmacology. So let me orient you to this diagram. Think about why somebody would be taking a medication. Generally, in the process of a patient being prescribed something, the first step is that there's a diagnosis. So someone figures out that there's a problem, the prescriber. Once they figure out that there's a problem, they develop a therapeutic goal. So in determining that goal, they're generally going to use the literature to help develop that goal. So for example, if the patient was diagnosed with high blood pressure, then the therapeutic goal will be to lower that to an appropriate range that's suggested by the guidelines or literature. So once the therapeutic goal is established, then a drug or maybe some other intervention is prescribed. In this course, we're talking about drug therapy, so for our purposes, we'll say that a drug is prescribed. So maybe the prescriber writes a prescription. Maybe that prescription's handwritten, or it could even have been typed into a computer and sent electronically to the pharmacy. So by the way, this picture you see here is pretty high level. I didn't include the dispensing steps here, but know that that is clearly part of this picture. So once the drug is prescribed, next the drug needs to be administered. And that could be by a nurse, it could be by the patient, or even a family member, or maybe someone else, depending on the setting. At some point after the drug is administered, you'll have a concentration of drug molecule at the site of action, and that's where the magic happens. You'll see a response. Maybe, going back to our example, maybe the response you'll see is that the blood pressure is lowered. So then, of course, at that point, you need to monitor that response. Did you see what you wanted to see? Yes. Was it not the response that was expected? Then the patient's therapy will be adjusted. Sometimes the diagnosis might be reevaluated, or maybe the goal is changed, or maybe even the drug is no longer prescribed, or maybe something different is prescribed, or maybe that original drug is still prescribed, but the dose is adjusted. And so you can see that this is kind of, something that could start all over again. So you start at diagnosis, go all the way down to response, come back up to monitor and adjust, and then depending on the outcome, different steps could be started over. But it's important to know that there are a lot of factors that can influence the drug response. So let's focus on these, as an understanding of these factors will help you in your ability to interpret the patient's response to treatment, as well as help you identify potential issues before medications are even administered. So some sources of problems. First of all, kind of looking down the right side of the slide, the light blue colored boxes. First of all, we have administration issues. So with administration issues, these are problems that, the patient was prescribed the medication and you're evaluating the response, but before you evaluate the response, you need to ask yourself, was the medication even administered? So things like medication errors. So maybe the prescription was dispensed incorrectly by the pharmacy. Maybe it was ordered incorrectly. These are all things that could, if the medication wasn't even administered properly, then your potential actions in terms of monitoring could be compromised. Another example, the drug source. Maybe the patient left their medication in the car overnight, or maybe they left the medication in the car for weeks, and so the drug source was compromised. Maybe the maybe the patient had issues with adherence. So you're evaluating the response, but maybe the patient was only taking the medication once or twice a week, or maybe once a week, or once a month. And so, in terms of evaluating that response, the response is clearly going to be different if the patient's not taking the medication according to the schedule that is prescribed. So, barring some of the above issues, if the drug is successfully administered, then for the drug to actually exert an effect, it's got to be transported by the bodily fluids, it's got to go across membranes, it's got to escape destruction and widespread distribution, and then it's got to actually reach that site, and a therapeutic concentration has to be available at that site. It's going to have to interact kind of with the body in a specific fashion. And what I'm describing at this point are the body's actions on the drug, and to some extent, the drug's action on the body. And those two factors are called pharmacokinetics and pharmacodynamics. So for the rest of this lecture, we're going to go into much more detail about pharmacokinetics and pharmacodynamics. So let's stop for a moment and let's just do a quick pre-assessment question for all of you. So which organ is primarily responsible for eliminating drugs from the body? So think back to your pathophysiology course and maybe some other courses that you may have had, and think about, what do you know about elimination, and which organ do you think is the most likely to eliminate drugs from the body? I'll give you a second to think about it. Well, if you said kidneys, then you are correct. It is the kidneys that are primarily responsible for eliminating drugs from the body. With that said, some of the other organs I have listed here also can eliminate drugs from the body, but overwhelmingly it's the kidneys that is the major organ that is responsible for eliminating drugs from the body. So let's talk about that middle box there, pharmacokinetics. So the reason I asked you that pre-assessment question is because as I discuss the next two factors, you will likely have some flashbacks to pathophys, especially with this first parameter, pharmacokinetics. Pharmacokinetics is the effects of the body on drugs. So there are four different parameters that make up pharmacokinetics. The first one is absorption. So the drug needs to be absorbed from the site of administration. Generally, that's the gut, but it could be other sites of administration. Once it's absorbed, then it needs to be distributed into the bloodstream to the target organs. Then it will be metabolized, and basically that's just the drug being broken down or biotransformed to be eliminated from the body. And so how it's removed from the body, like through the kidneys, is the last parameter, which is excretion. The pharmacodynamics is the effects of the drug on the body and where it works in the body, what organ and what response is seen. So think for a moment about factors that could influence either pharmacokinetics or pharmacodynamics of a drug. If you'd like, pause the video and write down some of your ideas. So hopefully you've kind of thought through what are some of the factors that could influence either the pharmacokinetics or the pharmacodynamics. And so hopefully you had some thoughts about this, and I promise after just a few weeks in this class, you will know lots and lots of examples. But let me mention a few right now. Pharmacokinetics. I think one of the biggies is age. So for example, newborn babies, especially preterm babies, usually have immature organ systems. like the kidneys. So the drug may not be eliminated as quickly from the body as maybe you or I could eliminate that drug, simply because those little babies have kidneys that haven't quite matured yet. On the flip side, elderly patients tend to have declining organ function, especially with respect to the kidneys. So these are two of the most at-risk populations for individual variation that impacts the drug response. Some other examples, just in general, patients with poor kidney function, these patients will clearly have impairments in excretion or even liver function, which is the organ that's primarily responsible for metabolism. If you've got a patient on numerous drugs that could interact with each other, these could impact both pharmacodynamics and pharmacokinetics, depending on what exactly the interaction is. Even genetic factors can cause variation that influence either pharmacokinetics or pharmacodynamics, such as a patient who lacks a specific drug target, meaning the site where the drug binds and does its job. So if a patient lacks that site, that drug receptor will not work and the patient won't have a response. So we will talk a lot more about individual variation as the semester progresses. Like I mentioned, these were just a couple brief examples, just to get your mind thinking about how factors, all of these different factors could influence the drug response. Okay, so let's talk more in depth about pharmacokinetics. Now, I already mentioned pharmacokinetics is simply what the body is doing to a specific drug. I like to think of kind of the roots of words. Sometimes it helps me remember what they mean. So the word pharmacokinetics actually comes from the Latin term pharmakon, which is drug, and kinesis, which is motion, which kind of makes sense. So I just said that pharmacokinetics is all about what the body does to the drug. If you think about it, pharmacokinetics is all about the drug moving through the body and kind of what the body is doing to it along the way as it's heading out of the body. And all of this can be described by these four parameters: absorption, distribution, metabolism, and excretion. So let's go into more detail about each. So I think I mentioned before, I like pictures. They help me visualize ideas and concepts. So we're going to use this picture to kind of help us walk through the different parameters of pharmacokinetics. So first you have absorption. So over on the left side of the screen, absorption generally occurs in the GI tract, although there could be other sites of administration. But basically, the drug is making its way into the body through, whatever that site is. And then the absorption step is getting the drug from its site of administration into the blood. Distribution is the blood, where the drug is going from the blood to the interstitial space and the tissues of the target organs. Metabolism is going to occur mostly in the liver, so you can see the liver is kind of at the top of the screen, but it could occur other places, but mostly in the liver. Basically, metabolism is enzymatically mediated alteration of a drug structure. This can also be referred to as biotransformation, detoxification, or even inactivation. These are just other words for metabolism. Throughout this course, we will use metabolism as our term of choice to describe this aspect of pharmacokinetics. So it basically, when you think about that definition I gave you, enzymatically mediated alteration of drug, really what that mostly means is that it's just the drug is being broken down in some way, shape, or form. Usually the drug becomes more polar, but there are other things that could happen. So once the drug is metabolized, then the drug is excreted. And so sometimes drugs are excreted in the bile. So straight from the liver, they go to the bile and then they go out of the body. Most drugs, however, as a result of metabolism, they're made more polar. They go to the kidneys and then they are excreted in the urine and they leave the body. So that's, kind of the picture of what it looks like for a drug to move through the body. One thing to mention, all aspects of pharmacokinetics are affected by how drugs pass across membranes. So absorption, distribution, metabolism, and excretion, all of these things are affected by how drugs pass membranes.
There's a whole big discussion on this in your book. Please don't feel as though you need to know all of that. I just want you to kind of have an idea that how drugs pass membranes is going to affect these different parameters. But basically, drugs can go through channels or pores. They can move via a transport system, or they can just directly penetrate through the membrane. For example, if a drug is lipid soluble, then it's very easy for that drug to pass through membranes. Most membranes in our body are made from lipids. So like I said, your book goes in a lot of detail, but what I just mentioned is pretty sufficient for understanding kind of the role of passing through membranes. So let's go into detail about absorption. So we'll talk about each of those 4 parameters in detail. So first of all, what is absorption? As I mentioned, it's movement of drug from its site of administration to the blood. So on this slide, you see rate of dissolution, rate of absorption. These are factors that affect absorption. Frankly, we don't have a lot of control over these things. They have to do with the properties of the drug. They have to do with the site of administration. Frankly, drug companies are going to formulate drugs in such a way to maximize the dissolution rate and to maximize the rate of absorption from wherever they are expected to be administered. I do think, though, the last bullet there, completeness of absorption, that is something that as clinicians we can have a role in affecting. Completeness of absorption can be impacted by changes in anatomy, can be impacted by drug or food interactions. And the completeness of absorption is important because it is indicative of how much drug actually gets into the bloodstream, and then, of course, how intense the response is as a result of that. So I want you guys to think for a moment, what kind of changes in anatomy could impact this? If you thought maybe a patient with short gut who can't absorb medications, a patient like that could probably be something that could impact the completeness of absorption. Or, other factors, I already mentioned drug or food interactions. So if a drug needs to be given with food, and when it's administered, it's not given with food, then you can anticipate that would impact the completeness of absorption. Or even something like, going back to anatomy, or physiology, even a patient with profound diarrhea, if the drug is moving through their GI tract too fast, they may not absorb it to the extent that they would otherwise. So these are factors that we can consider, when we're administering medications, thinking about, will there be an impact here? And then furthermore, if you're looking back to see, well, why didn't my patient respond? Thinking about, well, did the patient actually absorb the med is something that would make sense. So another factor to understand around absorption is the impact of the route. So, oral versus IV versus IM versus sub-Q, the pattern of absorption for each of these is unique in terms of how quickly they're absorbed, how completely they're absorbed. If you think of the IV route, that's 100% absorption, so to speak, because you're directly injecting it into the bloodstream. So there really is no absorption in that step. You're just putting it directly into the bloodstream. So of course it's 100%. Whereas an oral medication, maybe, it takes a couple hours for the medication to get into the bloodstream versus the IV route, which would be, you'd see an immediate effect. So there's a graph on the slide, and you can see, just different routes and kind of how those different medications, kind of what it looks like graphically for those medications, kind of in terms of how quickly they're absorbed and then to what extent they're absorbed. And you guys don't need to memorize this. This is really just to illustrate that these different routes are going to have different rates and extents of absorption. And on this table, this is actually from chapter 4 in your book. This is a nice table. You guys should take a look at it. It really just kind of characterizes the major routes, IV, IM, sub-Q, and oral, in terms of some barriers to absorption, the absorption pattern that you would expect, and maybe some disadvantages and advantages. So this is, not necessarily something that we might test you on, but I can tell you in clinical practice, having this kind of background knowledge will be helpful. And potentially, this is the kind of thing that you might get tested on for the NCLEX. One thing I do want to point out is the IM route. If you look at the table, it says that the absorption pattern is rapid as long as it's a water-soluble drug. However, if it's a poorly soluble drug, a lipid, maybe something formulated in a lipid base, then it's going to be a slow absorption. And because of that, you can use a depot release system. And so basically, for these medications that are formulated in this lipid base, they're injected into the muscle, and then they'll slowly release over days or even weeks. So that's an important thing to know, because a dosage form like that should not be given via the IV route. Because number one, the dose would be way too high, but also because it's got that lipid base, it may not be appropriate to give it intravenously. It could cause serious problems. All right, so thinking through those different routes and understanding that the pattern is unique, and because of that, the rate and extent of absorption is going to vary by route. But what else? If you think back to our first intro lecture, we talked about dosage forms. So I just want to bring up here that your dosage forms can also impact your absorption characteristics. So for example, if you're using a modified release system, a tablet that releases the drug over 24 hours, that will certainly have an impact on the rate and extent of absorption. So thinking about the routes, but also thinking about the dosage forms in terms of the absorption characteristics is important. So the last concept I want to review before moving on to distribution is bioavailability. This concept is important when talking about oral medications. It's not generally an issue we worry about since the dosage forms have been designed with this in mind. So the drug company is thinking about bioavailability. They're going to optimize the dosage form and put it out on the market. However, it is something that patients ask about, and the context generally that patient asks, that you'll receive questions from patients, is this drug's available as a generic, but it's also as a brand, and the brand is 10 times more costly than the generic. Do I really need the brand? And I would anticipate that you guys will get that question, regardless of the setting you work in. I would anticipate you get that question. So think for a moment, what would you say? What would your answer be? Is it okay? Can you just switch between the generic and brand? Or are there any situations where it may not be appropriate, or it may not be in the patient's best interest? So, to answer that question, I think what you need to have a basic understanding of is how the FDA basically says that the generic and brands are equivalent. So they call that bioequivalent. But really all that means is that they're equal. The generic and brand can be equally interchanged. Most drugs on the market that have both a brand and a generic version are considered bioequivalent, and you can readily change between those products. The FDA requires the generic drug company to do what's called a bioavailability study. Before they say, yes, they're equivalent, they have to do these studies. The thing about these studies is that they have a pretty wide margin, and they have to be within plus or minus 20% variation. So the response that you see from this medication from a pharmacokinetic perspective has to be plus or minus 20%. So I don't know about you guys, but that's pretty wide if you really step back and think about it. Now the good thing is, for most drugs, even if they are 20% different, it doesn't make a difference. For most drugs, there's a pretty wide range of dosages, and so Tylenol is Tylenol is Tylenol, so to speak. So if you use the generic version of Tylenol or you use the brand name version, for the most part, you're probably going to get the same results. But I think for you guys, my question is, can you think of a situation when you may feel differently? Think about a potential medication that a patient would get that, in your mind, the generic and the trade being 20% different could be an issue. One situation I can think of is a patient receiving warfarin. Now, you guys may have heard of warfarin. It's an oral anticoagulant drug. It is monitored and dose adjusted solely on levels. There is never a case where there's a standard dose that we use. It's always monitored by levels. And those levels are pretty precise. And for the life of the time, I'm sorry, let me say that differently. For the duration of the time that the patient is taking warfarin, it's always monitored by levels. So if you have a plus or minus 20% difference because the patient's been getting generic and then next week they change to the trade product, that could actually be significant enough to impact those blood levels. Warfarin is what we call a drug with a narrow therapeutic index. There are a handful of drugs that fall into that category, and those drugs, we say that the difference between the effective dose and the toxic dose is pretty small. So if you have variation, that's where you can have a problem. So in terms of bioavailability, just understanding the amount of drug that reaches systemic circulation. And really, when this comes into play is with your generic versus your trade name products and whether or not it's okay to kind of interchange between those. Most of the time, it's fine, but in cases where the drug has a narrow therapeutic window, we would be very hesitant to make that change so readily, especially without intense monitoring. All right, so let's move on to distribution. Remember, distribution is about where the drug goes after it's absorbed. So the factors that impact this, I think some of these are probably common sense. Blood flow. So if you've got a lot of blood flow to that particular tissue, then the drug will probably be distributed well from that site of administration. How able is the drug to exit the vascular system? So can the drug easily get into the brain? So if it's a drug that we need to treat, some type of CNS infection, but we know that the drug just won't pass into the brain, well, then we probably can't give it orally or even intravenously. Most likely we'll have to give it directly into the brain cavity so that it can exert its actions there, because otherwise it won't get into the brain. So thinking about how can it exit the vascular system, and then the ability of the drug to actually enter the cell. So even if it leaves the vascular system, can it get into the appropriate cells that it needs to get into? So these are some of the things that you think about. And going back to why these factors are important, they're going to impact the dose and they're going to impact the route of administration. Probably more than anything, they're going to impact the route of administration. Like I mentioned, if you've got a place where drugs just don't easily traverse membranes like the brain, then you're probably going to have to do something different to get that medication into the brain. Sometimes it's that you give it by a different route. Sometimes you just give a super duper whopping dose and then you hope that some of that dose gets into the site of administration. So distribution, while not a huge issue, in some respects can be a problem. Like I said, I like pictures. So this is a picture of drug movement across the blood-brain barrier. So you can see the yellow circles are lipid-soluble drugs, and you can see those just entering right into the brain because they can kind of go through the like dissolves like, and so the lipids can dissolve right through the lipid membranes and get into the brain. Drugs that treat pain, drugs that treat CNS disorders, generally those drugs are drugs that are lipid soluble and they can just pass right into the brain. Ionized drugs or polar drugs, or what we would call water soluble drugs, those are the little blue circles on the screen, and you can see that those can't make it through because there's tight junctions in between the capillaries in the brain, preventing things from just passing freely into the brain. That's like the body's own defense mechanism. And so those little water-soluble molecules that might pass through membranes in other parts of the body can't do that in the brain. And so they're trapped. So only way to get them into the brain is to make them either lipid-soluble or capitalize on some kind of transport system that actually helps transport those into the brain. So again, this is a detailed, but we're just trying to provide some background into, when we start talking about drugs and I say that it won't pass the blood-brain barrier, you kind of get the idea, oh, okay, I remember from the beginning of class why certain drugs don't pass the blood-brain barrier. Another issue with distribution, and another factor that affects distribution, is protein binding. So albumin is without a doubt the most important and most abundant large protein molecule that drugs attach to. But the problem with this is you can see the little black dot is the drug. When it bounds to albumin, the size is much, much larger than that little black dot on the other side that says free drug. And kind of the impact of that, again, looking at a blood vessel and looking at, protein-bound drugs within the vasculature trying to get out, you can see that those big green circles with the little black dots attached to them, they're not going to get through those small channels. Only that free drug is going to get through the small channels. So, when this comes into consideration is, if you have a patient with low protein, low plasma albumin, then they're going to have more free drug in their blood system. Or if you've got a drug that displaces another drug from that protein binding site, again, they're going to have more free drug, and that more free drug is going to leave the vasculature, get to its site of action, and cause a response. And so you could have potential toxicity in that scenario. The good thing is that the body usually quickly compensates for this by excreting more drugs. So it takes a day or so for the body to kind of fix this problem, but you could acutely experience some toxicity if you've got, for example, a drug interaction that causes that problem. But for your purposes, just knowing that this is another way that distribution can be limited in the body. All right, so let's move from distribution and let's talk about metabolism. So metabolism, like I mentioned, it usually occurs in the liver. I would say almost exclusively metabolism occurs in the liver, but there are some other sites in the body. And there are two types of metabolism, phase 1 and phase 2 metabolism. Really, phase 1 and phase 2, what you need to know there is that these are just different types of enzymes. So you have phase 1 enzymes, also called the P450 enzymes, and these just perform a variety of chemical reactions. And then you have phase 2 enzymes, which also provide, catalyze, a variety of different actions. But in the end of the day, for both of these enzymes, really what they do is they metabolize drugs. And I guess, in terms of the difference between phase 1 and phase 2, I guess the most predominant difference is that there are a lot of drug-drug interactions with the P450 system. So because the P450 system these enzymes are so largely responsible for drug metabolism, it's possible that certain drugs that are metabolized by the same system could interact. So one could crowd the other out from getting metabolized, and then you could potentially be in a situation where the patient is toxic because the drug didn't get metabolized because that enzyme was too busy metabolizing a different drug. Both of these enzymes systems can be affected by age or nutrition. In the end of the day, both phase 1 and phase 2 involve reactions that make the drug more polar. And this is a good thing, right? Because if the drug's more polar, it's going to be able more easily to be excreted from the body in the urine. So, in the end, that's kind of what both of these systems are responsible for doing. That's not the only thing they do, though. So, I don't want to leave you with the impression that the only job of these enzymes in the metabolism process is to just make drugs more polar. Without a doubt, overwhelmingly, that is their biggest responsibility. If you look at this figure, this is actually from your book. Don't worry about all the chemical structures. It's really just, it just kind of illustrates that there are multiple different outcomes, so to speak, of drug metabolism. So across the top, promotion of renal drug excretion, which basically means the drug is made more polar. So through either the phase 1 reaction on the left or the phase 2 reaction on the right, both of these compounds are now more polar and they're more readily available to be excreted in the urine. But that's not really the only thing that could result from drug metabolism. Number 2, activation of drugs. Inactivation of drugs. So in the second picture, the drug is active, but then it's inactivated. It's not necessarily more or less water soluble, but it's just inactivated, and then it can be excreted from the body in any number of ways. In the third example, I think this is a really interesting one. After the drug is metabolized, it becomes more active. So that's what you're seeing in this picture in the diagram for number 3. You see codeine being converted to morphine. And I'm sure you've all heard of codeine. Codeine is an opioid analgesic. It's pretty commonly prescribed. The thing about codeine is that the majority of its therapeutic action comes from its active metabolite, which is morphine. So almost all of codeine gets converted to morphine, and that's really how the patient experiences pain relief as a result of the morphine that's acting in their body. So again, just another interesting result of metabolism. Number 4, activation of a prodrug. And a prodrug is basically a drug that's not active when it's administered. But then once it's in the body, it's metabolized to the active compound. Again, this is also kind of rare, but and certainly a unique outcome of metabolism, but definitely something to be familiar with, because there are some big drugs out there that are prodrugs when they're administered. For example, Plavix, clopidogrel, you may have heard of it. It's an antiplatelet drug. It's a very widely prescribed drug. It is a prodrug when it's administered. And then the last one I want to talk about is number 5, and that's where you either increase or decrease toxicity as a result of the metabolism. Frankly, this is usually a decrease in toxicity, because the whole point of all these physiologic systems is to prevent the body from being harmed. But there are some examples where toxicity is increased. One that comes to mind is when meperidine, another opioid, when that is metabolized in the body, a portion of it is metabolized to normeperidine. And normeperidine is actually a pretty toxic compound. It's pretty toxic to the kidney tissue. And because of that, we rarely use meperidine anymore in clinical practice. So again, for purposes of our class, just kind of having an understanding of the different things that happen during metabolism, but definitely with an eye on the main thing that happens is that the drug is made more polar so that it's easier for it to be excreted from the body. One thing I do want to talk about in reference to metabolism, this is kind of like, just a little subset of metabolism, but it's a super important subset that definitely bears mentioning. So for drugs that are avidly metabolized by the liver and given orally, so that and is very important. They have to be drugs given orally. When these drugs are absorbed from the gut or from the GI tract, they go straight to the liver via the hepatic portal vein. And when they're in the liver, they can be extensively metabolized. So if the drug properties allow it to be extensively metabolized, when it goes to the liver and then goes to the systemic circulation, you may or may not have any drug left at that point. So think about if you're a drug company, how do you get around that? What things could you do to make sure that the drug actually gets into the bloodstream and doesn't just get destroyed in the liver before it actually reaches the systemic circulation? So you may have thought, well, you could just give it directly into the systemic circulation. Maybe you just give it IV. And so for drugs that have a high first pass metabolism, and in many cases, that's just what's done. They're only given intravenously. But in some cases, drugs that have a high first pass metabolism can be given orally. And in that case, what needs to be done is that the dose needs to be very high so that when the drug goes through the liver, some of the drug is metabolized, or actually a lot of the drug's metabolized, but the amount that you need for a therapeutic effect will still reach the systemic circulation. So there are, like I said, quite a few drugs that kind of go through that process. So, like I mentioned, just because the drug has a high first pass effect, it doesn't mean that it technically couldn't be given orally. It just means that the dose is going to be much higher when it's given via the oral route compared to the parenteral route, the intravenous route. I didn't mention this before, but both sublingual and nasal also avoid the first pass effect. So if you have a drug that's conducive to either of those routes, you could use those routes also to avoid the first pass effect. What you guys need to know, without a doubt, this is super important, not just for our class or for your NCLEX, but for your nursing practice. You need to know that the dose for any of those routes is going to be lower than your oral dose. And you need to be very cautious. If you've got a patient that's coming in on an oral dose and maybe they're not taking oral meds and all their meds need to be converted to intravenous, and it's a medication that has a high first pass effect, like a beta blocker or a calcium channel blocker or an opioid, if the oral dose is given intravenously, that is going to harm the patient because the oral dose is way too high for what is needed via the intravenous route. So be very, very cautious. Definitely keep this first pass effect concept in your mind. And whenever you're converting between routes, make sure that the dose is appropriate based on whether or not there's a first pass effect for that oral medication. All right, so moving away from metabolism, let's talk about excretion. By far, the kidneys are the absolute most important organ for excretion. there is some role for the bile, which comes from the liver, that also plays a role, very, very small role for sweat, for breast milk. Although, the breast milk question is very important for the baby. So if the drug, whether it's polar or non-polar, whether or not it's going to get into the breast milk, and then being very conscious of whether it makes sense for the mom or the parent to continue to breastfeed, despite the risk that that medication could get into the breast milk. So it becomes a question of, do you change to a different medication? Do you not use the medication at all? Is it safe to continue to breastfeed, and so forth? So there's definitely a lot of thought that goes into that. And then even expired air, specifically the anesthetics are excreted in air. For the most part, though, we're really thinking about the kidneys. So let me just remind you guys of kind of the physiology around the kidney. I know you've seen this before. Think back to your physiology class. When we think of the processes that are going on in the kidney that contribute to drug excretion, we're really just kind of talking about three systems. So it starts kind of at the top. You've got your glomerular filtration, and essentially small drugs are just pushed out of the blood in the glomerulus into the urine. And this is just really through osmotic pressure. And so any drugs that are small or low molecular weight, they're going to be easily pushed out into the urine. And then they travel down the renal tubule. And this is where that whole concept of, is the drug polar or not, becomes important. So if that small molecule traveling down the renal tubule is lipid soluble, at that point it can be reabsorbed through passive reabsorption. And again, that's why in many cases metabolism results in these polar drugs, because if you look down a little further, if it's a drug that's not lipid soluble, it's not going to be able to be reabsorbed, and it's going to stay in the urine and get excreted in the urine. And then the last role of the kidneys in terms of excretion is active transport. So if you've got really big drugs or high molecular weight drugs, maybe items or drugs that are bound to other things like proteins, then they're not going to get through the glomerular filtration process. They're going to have to be pumped out of the blood into the urine to escape the body. So there'll be special pumps. And so clearly not all drugs get out this way, but certainly some drugs do. So there are factors that can influence all of this. Manipulating the pH of the urine. So this can have an effect on whether the drug is going to be in a polar state or not. The transporter itself. So if you've got drug-drug interactions occurring at that transporter, and one drug is competing with another drug for transport out of the urine, then that could impact whether or not the drug's excreted. And then just in general age. So the nephron's not working well, or maybe they've stopped working well due to atrophy. And this is, a particular concern in the geriatric population. So for excretion, I think the main thing we're worried about, particularly with drug therapy, is the drug going to be eliminated properly? Some of those examples I just mentioned, it may not be. The excretion might be slow. So if you've got slow elimination, then you're going to have a lower dose. Clearly, because the drug's going to hang around in the body longer, so you would anticipate that you would need less, or maybe you would dose it less frequently. You might keep the same dose, but you might extend the interval. One thing to be aware of, don't just go based on your serum creatinine, because somebody who looks like they have a normal serum creatinine doesn't necessarily mean they have normal renal function. So for medication therapy, we're not just looking at serum creatinine on its own, we're looking at creatinine clearance. We might even be actually looking at actual GFR. But keeping in mind that some of these issues with excretion, specifically slow excretion, generally are caused by poor organ function, could be age-related or otherwise, maybe drug interactions, or maybe just genetic predisposition to eliminating something slowly. All right, so now we've talked through all those pharmacokinetic parameters. So absorption, distribution, metabolism, and excretion. Let's think for a moment about sources of individual variation that could have impacted these processes. I mentioned a couple, before I started going through the slides, I mentioned a couple, but I'd really like you guys to stop and think for a moment. See if you can come up with any others now that I've actually explained these 4 parameters. So why don't you pause the tape for a moment, write down a few thoughts, and then I'll go through some examples. All right, so hopefully you were able to pause the tape and think through some examples. But let's just kind of talk through, absorption. I mentioned in the beginning, but bears mentioning again. Maybe the medication needs to be taken with a specific, with food, for example, in order for it to be absorbed. So if you're not taking the medication properly in terms of, administration, that's going to potentially impact absorption. Could even be diet, could even be other medications that block absorption of medications or dramatically improve absorption of medications. Distribution, so we talked about protein binding, right? So the fact that the drug is going to be stuck in the bloodstream, or maybe not stuck in the bloodstream. If you've got a low protein, plasma protein, and the drug just doesn't have anything to bind to, then you're going to have more free drug. So, that could impact your distribution. Metabolism. I think with metabolism, probably the thing that stands out more than anything else is drug-drug interactions. So because the enzymes that are responsible for metabolism are utilized by lots of different drugs could potentially interact and impact another drug's ability to be metabolized. So this is probably the most important source of variation that we get concerned about. And then, of course, excretion. I think this one's easy. The obvious one is, elderly patients and their natural decline in nephron volume that, impacts their ability to eliminate medications as quickly as, maybe a younger patient who has. So before moving on to the next topic, which is pharmacodynamics, I want to review the time course of drug response. I think it relates back to pharmacokinetics, and to some extent it informs what we mean by pharmacodynamics. So let me do that now. And then after that, we'll move on and we'll talk about pharmacodynamics. All right, so now we're going to talk about the time course of drug response. So the major determinant of the time course of drug response in the body is pharmacokinetics, so absorption, distribution, metabolism, and excretion. Generally, the time course can be detected by evaluating the plasma concentration time curve, which is what you see here on this slide. So kind of along the x-axis is the time, and on the y-axis is your drug concentration. You can see your doses administered kind of at time 0, and then you can see, it's absorbed, and then it's eventually excreted, from the body. What you see on this screen is the concentration time curve for one dose of a drug. But you can see that the blood concentration is rising over time. It peaks and then it declines. So first question I have for you guys is, how do you think in this case this medication was administered? Do you think it was given intravenously? Hopefully you said no. Because if it was given intravenously, you would expect that peak to just go up immediately because you're putting the drug right into the bloodstream. In this case, it kind of gradually rises. So this kind of leads me to believe that this was probably an oral medication that was administered. A couple things I want to point out on here, important parameters that help us to evaluate this plasma drug time curve. You've got your minimum effective concentration, and then you've got your toxic concentration. So when we say minimum effective concentration, this is really, the lowest dose that's needed to produce a response. And then all the way up at the top, the toxic concentration is the lowest toxic dose you might see to prevent or to produce toxicity. And then really your sweet spot is kind of in the middle, or that therapeutic range. And that's where you see effects, but you don't see very toxic side effects. So these are all important ideas. Now, one thing I want you to remember is this is just for one dose. We don't usually do this for one dose. Normally, for most medications, we give multiple doses or continuous doses over time. And when you give multiple doses, this picture looks a little different. You see the drugs start to accumulate. And so, as the drug's accumulating, another concept comes into play, and that is half-life. And so half-life is the time for the concentration of a particular drug to drop by 1/2 in a particular patient. And so there will be published information about what the typical half-life is. So based on looking at hundreds or even thousands of patients, what's the typical half-life? And this is usually established in those pre-marketing trials. Just so you know, a half-life could be seconds, it could be minutes, it could be weeks, it could be months. In some drugs, it's years. In some of the radioactive pharmaceuticals that are used, the half-life could be years. And so, really kind of, if you think about this, it's how long for you to get to that point where the concentration is kind of constant. How many doses do you have to take until the drug accumulates enough so that you achieve what's going in is what's going out? And that's what we call steady state. So let's look at kind of a picture of what that looks like. So, this drug, for example, it's given once a day. So it's given on day one, and the grams in the body are 2. Given on day 2, right before it's given, it drops down. It's given again, and it goes up to 3 because you've maintained that 2 plus that 1 that was not quite eliminated. And then the pattern goes on, and you can see at some point you reach a plateau. And what that plateau is just what you're putting in each day when you take the medication is what's been excreted. So you're basically maintaining that steady state. And, for this particular drug, the dosing schedule is 2 grams given once a day. And then note that beginning around day 5 is when, which is about, 4, almost 5 half-lives, that's when you start to notice that you've got that plateau. And the reason I point that out is because we say it normally takes 4 to 5 doses before you see your steady state reached. And so again, steady state is just what you're putting in is equal to what the body is actually getting rid of in that same time frame. So your blood concentration remains steady, so to speak. That's why we call it steady state. Now my quick question for you guys was, does this mean we're in the therapeutic range? Remember I said we've got the minimum effective concentration and the toxic concentration, and somewhere in there is your therapeutic range. Unfortunately, just because you've reached steady state doesn't necessarily mean you're within the therapeutic range. If the dose you're giving is too low, you will eventually reach a steady state where what you're putting in is equaling what you're putting out. But the problem is if what you're putting in is not enough for you to be in the therapeutic range, you're still not going to be in the therapeutic range. So like I mentioned, 5 half-lives to reach steady state. And so you can just kind of see on the table we have here, about 97% of the drug percent of max concentration is reached by 5 half-lives. But even 4 half-lives, 94%. So some people say you reach steady state in 4 half-lives. Some people say 5 half-lives. For our purposes, it's about 5 half-lives to reach steady state. So let's conclude this part of the discussion with just a review of drug levels, because some of this information about curves and kind of when you reach steady state and the half-life of the drug, really the reason that's important is because for some drugs we actually dose them based on levels. And the reason why we do that is because the blood's a pretty easily accessible body fluid, and blood concentrations often are studied to determine how they relate to the drug concentration at the site of activity, and conclusions can be drawn from that. So, dose-related effects of the drug are then correlated with a given blood concentration or a range of concentrations. So once that relationship has been established, we can use concentrations in the blood to actually monitor therapy. And nurses are almost always a very active participant in this process, particularly in the inpatient setting. But things to think about. As a nurse, in many cases, your part of this process will be administering medications that might have blood levels drawn, accurately documenting when those medications were given. You may even draw the drug level depending on where you work. I know sometimes in the ICUs, nurses will administer the medication and also draw levels. So, thinking about being very precise about those actions is important. But also, if you're administering a medication that you drew a level on, do you need to wait before the next dose should be administered? Should you wait for the results to come back before you give that dose? Sometimes yes, sometimes no. I guess it depends on the patient and the scenario and the medication. What if the result is outside the therapeutic range? Then what? What does that mean? Does it mean that the patient's toxic? Does it mean they got the wrong dose? Why would they be outside of the therapeutic range? What actions would you take? So these are all questions that you would think about as part of monitoring medications that are uh, really adjusted based on drug levels. When we come up to specific medications that are adjusted by levels, I'll talk more in detail about that for that particular drug. But for now, these are just kind of, general concepts that you should be aware of. All right, so far in part one, we talked about pharmacokinetics, and then after that, in part two, we talked about the time course of the drug response. Now in part three, let's talk about pharmacodynamics. So pharmacodynamics is the effects of the drug on the body. Unlike pharmacokinetics, where we said it's the body acting on the drug, pharmacodynamics is really the drug on the body. And so this is your response to drug therapy. It's really kind of what happens when a drug is administered to a patient. What response do you see? So the initial step in this is for the drug to bind to a receptor, followed by a response, and this can be influenced. So just like pharmacokinetics could be influenced by individual variation or sources of individual variation, pharmacodynamics can also be influenced. So there could be issues with the drug receptor binding or the response at the drug receptor. There could be functional state issues with the patient, placebo effects, and other things. And we'll talk about these as we go through this part of the lecture. So pharmacodynamics, like I said, what a drug does to the body and kind of how it does it. Important concept here is the dose-response relationship. So the size of the dose compared to the intensity of the response produced. That's what the dose-response relationship is. And drugs generally have a graded response. And so the more drug you give, in general, the more intense the response you will see. So a couple, a couple concepts that kind of help explain pharmacodynamics: maximum efficacy. And so this really refers to what is the maximum achievable effect of a particular drug. And when we talk about this, we're usually talking about a good effect. I guess it could be a negative effect, but we're normally talking about a good effect. And so, once the maximum efficacy is achieved, adding more drug will not increase that particular good effect. However, it could increase toxic effects. And so that's an important thing to understand. Sometimes we just want to keep pushing and pushing and pushing the dose, but at some point you have to say, I'm not getting any more therapeutic benefit here. Now all I'm doing is putting my patient at risk for potential side effects. The other concept is relative potency. This is nowhere near as important as maximal efficacy, but I do want to point it out. Your book goes into detail about it. This refers to the amount of drug necessary to attain a given effect. This is really not an important idea, except when you're comparing two drugs. So if you're comparing, for example, two opioids, and one of them is more potent than the other, that's going to translate into the dose that you use. So let me use a graph to kind of explain these concepts, just to help make them solid in your mind. Like I said, I like pictures, so this picture kind of helps me. So let's say we have three drugs. On the screen you can see a line for drug A, a line for drug B, and a line for drug C. Maximum efficacy is the first thing I want to point out. So maximum effect is on the vertical axis, and you can see both A and B, in terms of their max effect, it's both pretty high. If you trace the line all the way back over to the graph, it's probably around 90%. However, if you look at drug C, if you trace that line back over to the left side of the graph, you're looking at maybe 50%. So the maximum possible effect that the drug C can have is only 50% of the maximum effect that either A or B can have. And I mean, that's an important thing to know, because if you're trying to, for example, eliminate premature heartbeats, and you need, the patient's severe case, and you want to make sure that you eliminate like 90% of those premature heartbeats, you probably would prefer to use drug A or B, because that's going to be more effective at doing that. Now, potency, on the other hand, let's kind of look at the lines from a different angle. If you look at A, it takes, the curve here is that there's less dose needed. Dose is across Drug concentration is across the horizontal axis. So it takes a lower concentration of drug to achieve the same response, both A and B. So we would say that A is more potent than B. Now, if these were opioids, which is generally when we talk about potency, we might say, for example, hydromorphone is more potent than morphine. You're going to need a lower dose of hydromorphone to see the same therapeutic effect that you would see from morphine. And that becomes important when patients start to be converted from one opioid to the other. If you were giving your patient 10 milligrams of morphine and they're changed over to hydromorphone for some reason, and you give them 10 milligrams of hydromorphone, they're probably going to end up in respiratory depression, because there's a big difference in the doses that you would use between those two drugs. And then you can see drug C is even less potent. You need even more drug, and it produces less effect. So like I said, this becomes important when you start talking, especially the potency stuff starts to become important when you talk about drugs like opioids, where you might convert between agents. So let's talk about the drug receptor theory. This explains kind of how drugs exert their effects. And so, I already mentioned that they bind to receptors, and then a series of events take place that ultimately create a response. Now, my question for you guys is, have you heard the term receptors previously? When did you hear that term? What was the context of that? If I had to take a guess, I'd say it was probably at least in your pathophys class, you probably talked a lot about neurotransmitters and the fact that neurotransmitters are endogenous chemicals that bind to receptors and produce effects. So receptors are just chemical sites in the body, and almost all drugs that exert a therapeutic effect do so by interacting with these receptors. And these receptors are just, they're not designed for those drugs that we're administering. They're designed for endogenous chemicals like hormones or neurotransmitters or other things. But the drugs are also able to bind and exert effects. So drugs aren't necessarily magic bullets. They really act through mimicking mimicking or blocking processes that are already present in the body. So it's kind of like helping the body help itself, depending on exactly what the drug's doing. So let's think back to pathophys for a second. You guys probably remember the neurotransmitter norepinephrine. And so what does norepinephrine do to the heart with respect to cardiac output? Think about that for a minute. So hopefully you thought about, you thought back and you thought, well, I know norepinephrine, and I know that that's like adrenaline, similar to adrenaline. And, epinephrine, norepinephrine, these neurotransmitters are going to increase my cardiac output. So if you have a drug that mimics the effects of norepinephrine when it's administered, then you can expect that it's going to increase the cardiac output. If you have a drug that blocks the receptor that norepinephrine normally binds to, then you can imagine that might decrease cardiac output. And so in many ways, the drug receptor theory is pretty basic. If you understand what the underlying process is, if we've got that much information, then you can kind of predict the effect it might have on the body. So one other important concept that kind of goes along with this is selectivity. Drugs tend to be, for the most part, highly selective. So they'll activate one specific type of receptor, they regulate a few processes, and the drug will have limited actions. This is the most desirable state. Unfortunately, not all drugs fall into that category. Some drugs will activate multiple receptors, and while they might have a positive therapeutic effect, they might also activate receptors that cause bad side effects that limit the use of that particular drug. But hopefully the drug is pretty selective. That would be the most desirable. So I kind of already mentioned these terms, but let me kind of wrap this up with an agonist activates receptors. So let me use that norepinephrine example again. If you've got a drug that mimics the actions of norepinephrine and binds to a receptor and activates that receptor the same way norepinephrine would do, then you can expect to see the same results as when norepinephrine itself activates that receptor. So if it's the heart, for example, then you might expect to see increased cardiac output. Sometimes you have a partial agonist. So this is a drug that can bind the receptor. For example, maybe it's a drug that's similar to norepinephrine. It can bind at the receptor, but it's not as robust at producing a response as norepinephrine itself may be. So in that case, those are called partial agonists. And then finally, you have antagonists. And these are drugs that they produce their effect by preventing the receptor from being activated and thus preventing the response that would have occurred had that receptor been activated by the endogenous molecule. So what I mean by that is they bind to the same receptor as norepinephrine, but when they bind, there's no response. And they not only do they not produce a response, but they block norepinephrine from binding to that site and producing a response. And so that's how antagonists work. And they're said to be either competitive or non-competitive. For you guys don't need to worry about that level of detail, but I will tell you what that means is that, if it's competitive, then it will bind to the receptor and then dissociate, and then the norepinephrine could also bind. The non-competitive ones, these aren't reversible. Once they bind, that receptor's done. It's gone. Your body has to regenerate that cell and that receptor to see a response. But like I said, that's a bit more information than you guys need to know. What I want you guys to focus on is the agonist versus the antagonist. What does it mean to be an agonist, and what does it mean to be an antagonist? Now, I don't want to leave you with the impression that all drugs act through this drug receptor process. I think most drugs do, but there are some examples where it's not a receptor-mediated action, and really it's just either a simple physical or maybe even a chemical reaction in the body that's producing the effect. So, for example, antacids neutralize stomach acid. So they literally bind stomach acid and neutralize its effects. They're not acting on a specific receptor in the body to do that. They're actually binding with the actual acid in the stomach. Saline laxatives. These cause the body to retain water in the intestines, and this is kind of through an osmotic effect. Again, has nothing to do with the binding of a drug to any specific receptor. Chelation therapy. So this is, for patients that have metal toxicity. The chelation will complex with the metal itself and make it more able to be excreted from the body. And then finally, antiseptics, the last example. These medications precipitate proteins and bacteria, and that's how they exert their antiseptic properties. So, like I said, there are a few examples of non-receptor mediated reactions in the body, but by and large, most drugs act through activating or blocking some type of endogenous receptor. All right, the very last thing I want to talk about here, and please, this slide looks crazy busy and it probably looks confusing, but don't let yourself get confused. Don't get crazy over this. There's just one really important concept that I want to make sure you guys grasp. I already started to talk about it, but let me tell you, first of all, let me tell you what you're looking at here. So up at the top, there's a long graph. Along the x-axis, you see dose, and along the y-axis is basically the number of patients. It's not really labeled well, but that's what you see on the x-axis. So basically, what you've got here is a determination of what the effective dose is, and that's what the ED50 is, versus the lethal dose. And the whole entire reason I'm showing you this is because, the typical effective dose for drug X is 10 milligrams. Some patients, you can see, this is just a distribution graph. So some patients maybe needed as low as 1 or 2 milligrams, and you can see some patients needed up to 20 milligrams. What you see all the way on the other side is the dose that was needed to cause a lethal dose. So in most patients, the 100 milligrams would have been considered lethal, although in some patients it might have been 90, and some patients it could have been as high as 110. So what I want to show you here is this big wide difference. So the difference between 10 milligrams and 100 milligrams is pretty wide. And you can see in this picture that there's no overlap. So some patients needed 20 milligrams to see a response, but no patient needed more than 90 milligrams, which would be considered lethal in some patients. That's a pretty safe drug. Whereas the drug below it, you can see that the effective dose in most patients was 10, but the lethal dose in some patients was 20. In fact, in most patients, it was 20. However, some patients needed 20 milligrams just to get a therapeutic response. So we would say that this is a very narrow therapeutic window. So that window between 10 and 20 is pretty narrow. In fact, it overlaps. This drug, there's probably no way that this drug would be marketed because it's too tight of a range. Like I said, please don't get crazy about this. Really, what I want you to take away from this is that there's this idea of kind of how safe a drug is based on the difference between the dose that most patients need to achieve a therapeutic response versus the dose that patients may need for that lethal or toxic response. All right, and that's really all I'm going to talk about for this background lecture, and really this is really important introductory lecture on basic pharmacologic principles. We'll talk a lot more about pharmacokinetics and pharmacodynamics next week, as well as throughout the rest of the course. But definitely spend some time on this lecture. Make sure you kind of understand just the high points. And if you have questions about the lecture, be sure to post them on the discussion board, and we can have some discussion around some of these concepts. Thank you for listening.
All right, so thanks for listening. I know that was a lot to take in. It really is the basis of what we're going to talk about for the remainder of the semester. So please don't hesitate to post questions to the discussion board, and we can have a more in-depth discussion on any of these concepts. We want to make sure that you're all as clear as you can be on this content. So thank you for listening.